Many thanks for coming. My name is Lambros Lazouras. I'm a professor of social psychology at Sheffield Harlem University, and I'm the project coordinator for Mindful Muscles. Mindful Muscles is a European project funded by the Erasmus Plus Sport program of the European Commission. We have partners from 7 countries in this consortium, and we are trying to develop new ways, preventive methods to tackle the use of image and performance enhancement drugs like anabolic steroids and many, many more, really, within the context of recreational sport and exercise. So in a few words, it's anti-doping work that we're trying to do, but outside the classic remit of doping, which usually tends to be elite and competitive sport. We're mostly now focused on recreational sport and exercise settings. One of the objectives of this project is to create a community of practice of early career researchers in the area of IPEDs research, image and performance enhancement drugs, from across Europe. And one of the objectives of this community is to disseminate more widely across Europe and across actually other nations as well, the research that is being taking place in this area. We're a multidisciplinary group, so we're planning to have more talks in the next few months from different disciplines. We're starting today with a very interesting study, the HAARLEM study that will be presented by Diederik Smit, a doctor, medical doctor, internist, endocrinologist, and currently affiliated with Tilburg Hospital in the Netherlands. So Diederik, many thanks for making the time and for wanting to present your research here today. I can see that we have a diverse and very interesting group of participants, attendees, and I'll give now the floor to you, and you can present yourself and your research. Thank you.
Well, thank you, Lambros, and thank you for the invitation. I was happy to accept the invitation because I'm already very excited to disseminate the knowledge that we acquired about the health effects of anabolic steroids, and it's widely used by so many men, and there's so little information about how hazardous it is and what the consequences are of the use of anabolic steroids in the long run. So I hope I'm going to give you a lot of new and fresh knowledge about health effects of anabolic steroids in the next hour. We'll talk to you about the outpatient clinic for anabolic steroid users and the HAARLEM study. I'll also introduce what the clinic is and what the study is and all the results that we have collected during the 5-year study period. I was a resident in internal medicine from 2013. That's when I started working in Harlem. That's where I met Pim de Ronde. He is the first and next to me only internist in the Netherlands who is acquainted with the topic in a way that he can actually deliver healthcare in an expert way. And he selected the outpatient clinic for anabolic steroids based on his experience with testosterone and anabolic steroid users in the past. And he selected the clinic first in Amsterdam and took it with him after a year to Haarlem. That's where we met. And I was still a resident and very keen on doing some research. And well, I joined him in the clinic, saw a few patients, and I was absolutely flabbergasted what I saw there, the terminology, the men that spoke, the complaints they had, and I was fascinated and intrigued by them. And I was really, really eager to work with him on this HAARLEM study project. That's where I started the project very, very soon after that. I think we started in 2015 after we got a grant, and we finished the study in 2019. And in 2 months, I will defend my thesis that is all about the outpatient clinic and the HAARLEM study. After I left Haarlem, I went to Amsterdam for 2 years, finished my residence, and from 2019 I work in Tilburg in the south of the Netherlands, and that's where I opened the second location of the outpatient clinic. Together we have the expertise center of anabolic steroids, and now we have 2 clinics, one in the north and one in the south, and we both see the same patients. Patients decide themselves if they want to go to Haarlem or Tilburg, but usually it depends on where they live, and they can get a consult with me or with Pim, and we try to help them as much as we can. So start with the clinic because that's the basic of our work. First, about anabolic steroids in general. I've been speaking to hundreds of users, and what was very interesting for me to learn is that there is a very large difference between the way men like to see themselves and the way women like to see men. On the left side, you see an image of the way men think they are most attractive, with the hair of Justin Bieber and the legs of Cristiano Ronaldo. And on the right side, you see an image of a man.
Diederik, I'm sorry to interrupt you, but we can't see the slides moving.
That's
sorry for that.
That's a waste. And they didn't move from the first slide.
No.
Then I'm just gonna end. Do you now see the second?
Yes, and I think that if you go to presentation mode, in the bottom of your screen, if you can go to the yes, if you click on that.
Do you now see the second slide?
Nope, we're in the first slide.
So it doesn't move along with the rest of
We saw it before, so yes.
Yes.
Yeah, but well, there are some animations that I won't be able to use. That's fine. Okay, so look at this picture. Now, on the left side, you see Jared Butler with the hair of Justin Bieber and the legs of Cristiano Ronaldo. So this is the way men want to look like. And on the right side, you see the face of James Corden with the hair of Prince Harry. And this is the way women think men should look like. And there's a very large discrepancy between men deem what is attractive and what women deem is attractive. And as a pioneer in this area, I always thought that men used anabolic steroids because they wanted to be more attractive for the female and the ladies. But that's actually not the reason why they use anabolic steroids at all. In a very small fraction of users, I've learned that they are interested in becoming more attractive, but in the majority, anabolic steroids is all about increasing their muscle mass and exceeding their own limits. And it's intrinsically driven. They do it for themselves and their own ambitions. They don't do it for the other sex. I'll just continue with the other slides. This is just some background information about anabolic steroids, what they are. They are testosterone derivatives. They very much look alike. They all have the same cholesterol core, and the adjustments are very minor, but they create different derivatives of testosterone that have a slightly different pharmacokinetic profile. Some adjustments make them render them possible for oral intake, and others are just injectable depots. When they attach a fatty ester, that is usually attached on the bottom side of the cholesterol molecule, you can inject them as a depot, which causes them to dissipate very slowly from the intramuscular site. So you can inject every once in a week, for example, or every once in 2 weeks. So that's the way testosterone is adjusted in a way to create different compounds, because the idea is that if you change the molecule, that the effect might be different as well, that they might be more anabolic or they might be more androgenic. So they have different purposes and different uses. That's the theory. In practice, the difference is not that big. There's even a large scientific group that says that the term anabolic androgenic steroids is a misnomer, because all steroids that are testosterone derivatives are both anabolic and androgenic. So it's double. You should call them just androgens. But that's the basis. The mechanism of action. Well, I'll just skip through this because I think that is not very important for you to know. I'll just remove this image. This is the side effects that I knew they existed. I just found them on the web when I was searching for literature starting the study. And this is just a summary of effects that we know exist in relation to the use of anabolic steroids, like acne and deepening of the voice in women, breast enlargement, high cholesterol, liver dysfunction and cancer. When you sum up these, you might get terrified by the effects of anabolic steroids. But what I was missing when I was searching through the data online is, so in what proportion do people suffer from these side effects? And when they suffer from these side effects, are they severe? Are they mild? Do they cause them to stop their use, or do they not mind them? Do they have ways to escape from side effects? So I knew more or less what the side effects were, but I didn't know in what extent they would occur in the users of anabolic steroids. So we were very eager to get an objective picture of the health effects of anabolic steroids.
Our technology here is a bleeding nightmare, isn't it?
Some of you has the microphone switched on, so make sure it's switched off. And what I'm going to talk about is the outpatient anabolic steroid clinic, the HAARLEM study. And in the HAARLEM study, there's a lot of information available about the characteristics of uses, the methodology of anabolic steroids, and of course the health effects. And I'll talk about side effects, blood analysis, fertility, and cardiac analysis, which are the major topics that we investigated during the HAARLEM study. So this is the logo of our clinic, our expertise center. It was selected mainly for these reasons. We knew that there were a lot of people using anabolic steroids in the Netherlands. And in the Netherlands, it's illegal to produce and trade anabolic steroids, but it's not illegal to use them and possess them as long as it's for personal use. And we know that they are harmful, like the slide I showed before with all the side effects, but precise data are lacking. There's never been large prospective clinical trials because if you want to do them in many countries, they're ethically unfeasible. Largely because anabolic steroids are not registered for use in humans. So if you would ever devise a protocol injecting anabolic steroids into your subjects, you would probably not get permission because these products are not tested as pharmaceutical grade compounds, and that you would have to do first. So the clinic was established in 2011 to gain more insight into the characteristics of use. What do they do? What type of people is it that uses anabolic steroids? And secondarily, also to help patients if they have health problems. And especially this part was very new. Users of anabolic steroids, if they would occur, would stumble upon health issues, they would usually not find much help in their general practitioner or regional endocrinologist. They would mostly not understand what happened or what the relationship of their complaints to anabolic steroid use would be. And it's a big frustration to a lot of IPED users. It still is. And we wanted to offer some kind of help from an expert who is familiar with the anabolic steroid use and the health effects, and offer help that is tailored to the patient. And that's what the clinic is all about. We made a small review between 2011 and 2016. There was about 180 patients referred to the clinic. That's just HAARLEM. And we made a comprehensive overview of all the patients that were referred. So this is complicated because there's animations here. So I will just have to move the images out of the way to show you all the images I want to show you. Let me see. I'll just show you the map of the Netherlands first. So all the patients that were referred to the anabolic steroid clinic, 180 in 5 years, mostly men, except for 2. Haarlem is here, Tilburg is here, and most of the patients were referred from the region. But also Utrecht, that is a little bit farther away, and also Brabant to the south of the Netherlands. But you can see patients were referred from throughout the country. So it had a nationwide service to the country, but you could really tell that patients would be referred, wanted to be referred only if it was nearby. They wouldn't want to travel all the way from here or there to visit a doctor for a consultation of 20 to 30 minutes. And this is the amount of patients that were seen over the years, which is fairly stable in the last in the 5 years that we analyzed. This year, the collection of data was not complete, and this is the year that the clinic was founded. So we see about 40 to 50 patients per year. That changed since I opened my clinic in Tilburg. I see about 60 patients per year. Wim de Ronde in Haarlem sees about 40 to 50 patients a year as well. So now we see about 100 patients per year in both our clinics. The reasons for referral are usually symptoms during or after the cycle. We have a condition that we want patients to be referred only when they want to finish their anabolic steroid use or when they finished their steroid use in the past. We don't want to treat patients that are still using and have an intention to keep using, because in that case, our advice would mostly be, if you experience problems during anabolic steroids, you should probably quit. But our main focus was the symptoms that occurred after the cycle, after they quit anabolic steroids, and they would not recover and they would still have these problems. The most occurring problems were the decreased libido, erectile dysfunction, mood problems, and fatigue. Gynecomastia we've seen a couple of times as well, and subfertility. Usually, the clinical question was whether there was hypogonadism, whether there was a testosterone deficiency that was induced by their anabolic steroid use. In all those cases with all these symptoms, that was the question, but sometimes the referral reason was explicitly whether there was hypogonadism or not. Some of them just didn't have any complaints, but wanted to have a health check. That's not really what we do, but sometimes you don't really control the people that are referred to your clinic. And there's a group of people that are still using, but want to quit and don't know how. So we help them taper off the steroids. Looking at the characteristics, we see that they have an average age of about 30 to 35 years, but we've seen patients between 20 and 60 years old. Many of them are bodybuilders or combat athletes. Most of them are working or employed. Some of them are students. And drug use is very common. That's something we've seen in the HAARLEM study as well. And indeed, 90% of the patients was not using anabolic steroids at the time of their clinic visit. Here again, I have to clear it up for you a little. We asked them about their history of anabolic steroids, and we found that they usually started in the beginning of their 20s, and they used for about 4 years. That doesn't mean they used non-stop, but at least 4 years in their life, they at least did one cycle. Some of them used continuously, which means they don't stop their cycle at all, and completed 4 cycles when they decided it was enough. Median cycle length was 10 weeks. And they use 3 different anabolic steroids during their cycle. And here you see a graph of how many cycles a patient completed. So most of them completed just a couple, but there were patients that did over 20 or even over 30 cycles. And cycle length, how long a steroid cycle was, it was on average about 10 weeks. Some of them a little bit longer. There were cycles that were longer than half a year. And many of them were shorter as well. We asked them about the types of anabolic steroids they used. Well, mostly testosterone, but trenbolone, stanozolol, nandrolone, methendienone are all very popular. So they use a mixture of anabolic steroids. It is kind of customary that they use multiple androgens instead of just the one. Usually when they do a cycle for the first time, they might do stanozolol only or testosterone only. But in the end, they usually start stacking the androgens together. Looking at medication, they used other stuff as well, usually to get rid of the side effects they experienced during anabolic steroids. And aromatase inhibitors are very popular for fluid retention or gynecomastia. They use HGG or Pregnil to keep their fertility on a right spot or to prevent testicular atrophy. Clomiphene, tamoxifen, that is used for gynecomastia as well, and another few medications. Post-cycle therapy, the period after the cycle when they quit their androgens and testosterone and they want to speed up the recovery of their own testosterone production. There are theories that post-cycle therapy might augment their recovery or fasten it up by administering anti-androgens or aromatase inhibitors. And it's very common to do so. In the HAARLEM study, we found that 80% of the participants did a post-psychotherapy, which is pretty much, there's no good evidence that it actually works, but in this area, evidence is not very important. Usually the advice that is on internet, the gurus, the most experienced users have the most important opinions, and scientific evidence is not really available, and it's not really important to most of the users. But PCT is very common and is used by most of them. Growth hormone was also very common. It's a whole different hormone than anabolic steroids, but does have some anabolic properties, so it's used quite often. Clenbuterol, thyroid hormone, insulin as well. So those are the other performance enhancing drugs, and many users combine the androgens with few of the others. Or, for example, they use growth hormone in between their cycles to keep their muscle mass on a certain level. We asked them about side effects. The most common side effects are acne, decreased libido after the cycle, and gynecomastia. They're quite common, but you can see there's a wide array of side effects that patients experience during and after their cycle: fatigue, fluid retention, perspiration, alopecia, subfertility. It is very unlikely that someone uses anabolic steroids and does not have any side effects, but these side effects are usually very mild and reversible, so they don't really withhold their users to keep on using. We did laboratory analysis in quite a few patients as well. We didn't see extremely dangerous stuff. We did see some polycythemia. We did see abnormal lipid profile, androgen deficiency after the cycle in quite a few, abnormal liver biochemistry. But this is data that is very hard to interpret because we did the laboratory analysis in just selected patients. So this is not a systematic way of assessing health effects. This will become much better visible with the results of the HAARLEM study. And we start treatment in selected patients. Usually we try to find a relationship between the symptoms and the complaints that they were referred with and possible hypogonadism. So that's the usual sequence of events: was listening to the story, summarizing the symptoms, checking if the testosterone levels were adequate or not. And if they were not adequate, they were probably related to testosterone deficiency. And if they were adequate, it's possible that the symptoms were not related to anabolic steroids at all. So in many cases, for example, with low libido or erectile dysfunction, we established that testosterone production was just fine, and that the cause was probably psychological or sexuological. So we gave a lot of reassurance and advice. We usually recommended those users to not use anabolic steroids again. But in cases in which it was indicated, we started pharmacological therapy. In case of gynecomastia, we started tamoxifen, and if that was not sufficient or refractory, we referred them to a plastic surgery. If there was reduced fertility, we helped them with tamoxifen or HCG. And if there indeed was hypogonadism, we started tamoxifen or testosterone substitution. And that's the way we still work. That's our protocol. We just try to link their symptoms to hypogonadism or not, and treat them if indicated. So this overview of our patients that we've seen on the clinic showed us that there's a typical visitor that is a male strength athlete. They usually start using in their third decade. They completed a couple of cycles in a couple of years' time, used a lot of medication, drugs, and other PEDs. PCT was very common, but the heterogeneity of the cycles was enormous. Every cycle is different, all different kind of combinations we've seen and heard. But basically the effects were very similar. And we did see an increased risk of health problems. Of course, there's this fanatical engagement in weight training that exposes them to exercise that might cause tendon ruptures or muscle injuries. We've seen that they very often use hard drugs, which has implications for health as well. And the adverse effects of anabolic steroids abuse I've explained. And to our amazement, we didn't really see critical health issues in this population. In this 180 patients, we didn't see anyone who died. We didn't see anyone who was admitted to the hospital because something really bad happened. But you have to be very careful about this kind of interpretation because you see a selection. You see a selection of patients that are referred to our clinic. So if someone would die, they would probably not visit our clinic anymore. If someone would be admitted to the hospital, they would probably be helped in their own region and not be referred to our clinic. So it's very hard to draw real solid conclusions from these data. And that's why we needed some systematic form of data collection. But it at least gave us some insight into the group of patients that sought help after steroid use. So this is what I explained. The retrospective nature makes it scientifically very weak. Incomplete documentation. There were a lot of patients who visited that had an incomplete report of their visit. Maybe they didn't recall all the problems they had or they didn't report them. And there was no standardized protocol for follow-up. So it was clear that we needed something better than this. And that's why we started the HAARLEM study. Health risks of anabolic androgen steroid use by male amateur athletes. This is me when I still had glasses, and this is Pim de Ronde. And we started this project in 2015. The purpose was to identify the characteristics of anabolic steroid users better than we did by summarizing our patients from our clinic. Describe again the methodology of current anabolic steroid use. We wanted to investigate the quality of anabolic steroids products used and study the health effects caused by anabolic steroids during the cycle and also after the cycle with a certain amount of follow-up. And long-term monitoring would be ideal, but we did a follow-up of 2 years. And of course, if you really want to know what happens in the long run, you would have to follow up this group for 10, 20, maybe even 30 years, and that's just not feasible. What did we do? We included males that were 18 years or older that wanted to start a cycle with anabolic steroids. We didn't want to include them if they just were diagnosed with a new illness or they were just admitted to a hospital. We didn't want to be responsible for any new health issues by allowing them to enter a cycle of anabolic steroids. And when they visited us, they were just ready to get on the way. So we did a health analysis before they commenced their cycle. Then they did whatever they wanted to do. They had to collect their own stuff, buy the anabolic steroids on the web or find it through dealers, and do whatever scheme or schedule they had in mind or devised themselves. We didn't give any advice. We didn't tell them what to do. We just wanted to do them to do whatever they would have done without this research project. So we would have an insight into the real life, real world anabolic steroid use. We would invite them to come back at the end of the cycle so we could do the health measurements again. And after they would quit the cycle, we would repeat those measurements after 3 months and again 1 year after the start of the study. So they would be included for 1 year. In the end, we included them for a second year, and we've invited them to visit again 2 years after the start of the first cycle. But this data I will not discuss today yet because the analysis is still not complete. But the most important part about health effects is in the first year. We hypothesized that there would be possible permanent damage. In that case, you would have a parameter measured at baseline and it would change during the cycle and it would not change back to baseline again. Also, a scenario is full recovery, that you see some derangement of a variable that changes back to baseline. We did this 3 months after the cycle measurement, and you could see whether it was on the way back to normal, or maybe in the third case, also full recovery back to normal even before 3 months after the cycle. So those were the possible outcomes of all the parameters we did. We investigated. I'll tell you later what these variables were exactly. The only thing that we actually did besides looking and measuring was that we agreed to intervene if there would be any serious illness. You have to imagine that the subject visited our clinic for a baseline measurement and did all types of health research, and we didn't disclose the information because we didn't want to give away the data, the results, because it might influence the way that they use anabolic steroids. So we would disclose all the results at the end of the year. But if we would find anything that would be really bothersome, in case they would really have to visit their own doctor, we intervened. This happened not even once, but we had to take the intervention into our protocol. This flowchart shows how we found our subjects. We had 220 subscriptions, and some of them were not eligible because they signed up, but we never heard from them again. They heard about the study design, but didn't think it was suitable because they wanted to do 2 cycles in the first year instead of just 1. They sometimes didn't want to stop at all. They wanted to continue their cycle throughout the year. And some other reasons. So 163 subjects were actually eligible. And when they were invited for the first visit, some of them already started the cycle, so that made it impossible for them to participate. They didn't want to start anymore or later, or they didn't meet the inclusion criteria. Some of them didn't meet the inclusion criteria because one of them was that they had to be off steroids when they started. And some of them were on a testosterone replacement therapy, so they weren't able to participate. And some of them just didn't show up. In the end, we included 111 subjects, and our aim was 100, but some of them dropped out in the first part of the research year. They postponed their cycle anyway, even after they enrolled, or they withdrew because they didn't want to participate anymore. It was too much of a bother to visit the clinic, and they didn't really see the benefits of it. But in the end, we had 100 patients that met the finish line of 1 year follow-up. Our first study subject was a celebrity in the Netherlands. He made a television documentary about his quest to become a Men's Health cover image. And along the way, he planned to use anabolic steroids, and he signed up for a study so we could co-participate. And we did him a favor because he got health analysis, and he did us a favor because our study got nationwide attention on the television. And after that, we didn't really have to do anything anymore because all the subjects we included after that automatically followed. So we didn't have to advertise or do anything to find our 100 subjects. So I'll tell you about the characteristics. It's fairly similar to what I described about our outpatient clinic. They were on average 31 years old, a body mass index of 27, which is not overweight, just muscular. Most of them were well educated. Almost all of them had work or were students. Half of them was living together or married. 1/4 of them already was a father. 93% was heterosexual. And recent drug use, just like I showed the previous data, is very, very common. 1/3 is using more than 2 types of drugs in the last 3 months, and amphetamine, cocaine, cannabis, GHB. It's fairly common for this group to use these kinds of drugs. All of them engage in strength training. Some of them in bodybuilding competitions as well. Weightlifting, strongman athletes, combat sports are the latter is fairly common. And looking at how much they train, they spend about 5 hours per week in the gym, which is quite much. I think that's very comparable to sportsmen that are very fanatic in other sports, swimmers, tennisers. They all spend about 5 to 6 hours at least in their venue. So I would have to say that this is a group of sportsmen that is really ambitious. It's not just a recreative strength athlete that goes to the gym once a week. And I asked them, of course, about the reasons for their anabolic steroid use. And like I said before, becoming more attractive was just important for 3 of them. But for most of them, it was about muscle growth or strength growth. They had a certain ideal body image they wanted to achieve. For a significant group, taking part in bodybuilding competition is a reason to use. They have to use because otherwise they're just not able to compete. It's about self-image in a couple of subjects or anti-aging purposes. But the reasons are quite various. If I've asked them, what's the reason that you actually engaged in your first cycle? They usually tell me that they are going at it with a group of friends. They used because someone else they know used and had good effects. Some of them did extensive self-study and did it on his own initiative. But the majority does have social cues. Are there users in your social environment? I asked them, and well, usually there are. In just 17%, there were no fellow users of anabolic steroids. So social environment seems to be a very important factor in this community. So the methodology of anabolic steroid use, this slide shows the follow-up of the 100 participants. The ideal course was the first line, the first row. So between T0, the baseline measurement, and T1, the end of the cycle measurement, they would spend their time on steroids, which is the red line, and they would get off steroids until the end of the year. But as the other rows show, it didn't go this way for a large part of the group. 10 of them did a new cycle after the 3-month measurement, and 5 of them just never got off the cycle. So even though we had this protocol or this ideal picture of how the year would look like, we weren't able to enforce them to it. They enrolled to our study. We asked them to do 1 cycle, but if they wanted to change their strategy or do another policy, we couldn't stop them. And we didn't exclude them. We thought all the data was useful. And there's a few rows that showed missed visits. So these 3 did 1 cycle, but didn't show at their last visit. So there's some data missing. And there was consent withdrawn by 2. So 2 of the subjects didn't make it until the end of the year. So 98 subjects actually finished the entire year with all the measurements. The cycle characteristics, so the real world data is that a cycle length is 13 weeks, but we've seen 2 weeks and 52 weeks with 5 different anabolic steroid types with a cumulative dose of 13.2 grams, which is 900 milligrams per week. But you can see that the variation is quite large. And a cycle cost is 400 euros for 1 cycle, so 30 per week, which is cheaper than a lot of other hobbies, I presume. And most of the products were acquired through dealers, acquaintances, or the internet. This slide again, showing all the steroids that they use, it's very similar. There are some minor differences between compounds that are popular or not, but testosterone is the mainstay of basically every cycle. Drostanolone and nandrolone and trenbolone are the big others, boldenone as well. But it's various. And actually it's not very important because even if they said they use trenbolone, it still remains a matter of debate whether trenbolone was actually in the vial that they used. I'll show you some data later on. Again, the data on what other stuff they used, again, growth hormone was very popular, clenbuterol, thyroid hormone, insulin, and the other medication that they used for issues encountered during their cycle, HCG, tamoxifen, and anastrozole, the same stuff as I showed you in the previous slides. Post-cycle therapy, again, here, very popular. 80% of participants used PCT for about 4 weeks with 2 different products. The variation here was considerably smaller than the variation in cycles. If you look at the cycles, there's not 2 subjects that did the same cycle. All 100 participants had a different cycle, but PCT was more similar among the users. And tamoxifen and clomiphene are the most popular in HCG as well, and there's a fraction of subjects also use different PCT compounds. And it's all about rebooting the endocrine system to produce testosterone again. But you're still not proven that it actually works. We did a compound analysis. We asked every participant to bring their stuff to the first consultation, and we would take a small sample of every product they would use and send it to the laboratory of the RIVM, which is a large institute for the government that does a lot of drug checks and pharmacological studies. There is more data than I'm just going to show here, but this is the data we had from the HAARLEM study. We did an analysis of 272 samples, which is not all of the samples used because we had a quotum based on the budget that we had. I think about the entire study, about 500 different samples were used, but only 272 of them were analyzed. And the interesting thing is that if you look at these data, the number of samples that contained only the anabolic steroid as indicated on the label. So if you have trenbolone, the chance that you would find only trenbolone inside your vial was 13%. The chance that you would find at least what is mentioned on the label was 47%. So which it means that in over 50% of cases, inside your vial is something different than is mentioned on the label. And in a lot of cases, it was different compounds. There was a little bit of testosterone, a little bit of boldenone, a little bit of nandrolone. There was not really a consistency among any brand. All of the brands were poor in terms of quality. We analyzed 46 brands and none of them did a perfect score. We did have to conclude that in most of the samples we analyzed, there were anabolic steroids. In just 6% of the samples, there were no anabolic steroids, which means whatever you buy, there's usually some androgen inside. So there's usually an effect. It's just fairly impossible to say what type of anabolic steroids are inside the vials that you buy. So much for the analysis of the product. Now we'll continue with the health effects. This is the most important part. First, we look at side effects or series of adverse events, which is the events that happened throughout this first year that would really cause a subject to go to the hospital or to require immediate care. One of them had heart failure, which is quite bad. He did have some genetic heart disease that he didn't know of before, but that's what the end of the analysis showed. But this damaged heart was confronted with the cycle, and that's when he decompensated and had to be admitted to the hospital. He was treated with diuretics and other medication, and he made a full recovery, but he never used steroids again. This is an example of a very severe side effect that is not caused only by the anabolic steroids, but by a combination of a previous, maybe undisclosed illness or condition that is just brought out of balance because of the steroids. And there are a lot of examples like this in literature, but it's very hard to say that the cardiomyopathy, so the heart condition, was caused only by the anabolic steroids. In this case, it was very unlikely because he was admitted to the hospital in this third week of the cycle. And it's very unlikely in 3 weeks he would develop this kind of heart disease. And he didn't really use anabolic steroids before this cycle. He used it twice, but very short cycles for a long time ago. So this was not likely to be the only cause. There was a patient with ulcerative colitis, a bowel disease. He had episodes of this disease outside of his steroid use, but in this year, he had an episode with an exacerbation of his illness during the cycle. So he quit and recovered well with therapy. We had one subject who had a pancreatitis. inflammation of the pancreas. He developed this illness in his last week of his cycle when he was preparing for a bodybuilding competition. And he had episodes like this before, and in the previous episode also was in the last week of his cycle. So there really seemed to be a relationship with between the steroid use and the illness. And there was one subject who had almost done a suicide attempt. He didn't really do it, but he was on the verge of doing it. He was known with psychotic depression even before he first used anabolic steroids. Which was very atypical, is that it happened during the cycle. And if you would expect anyone to become really depressed or attempt suicide, you would expect them to do it after the cycle. So if there's a relationship, we don't really know, but it was severe enough to mention. Looking at the side effects collected in a structural way, we have to admit that there's a lot of positive effects as well. And it's important to stress this if you want to understand why people do it. 100% of participants reported an increase in strength and almost 100% also in muscle mass. Fat mass is reduced and they have higher energy levels, they sleep better, they have enhanced concentration. So steroids have a good effect on your physical and mental health. So that has to be stressed. But all of them also reported negative side effects. Increased libido, well, in most cases, that was a negative, but there were some that were happy with the increased libido. But testicular atrophy, fluid retention, acne, agitation, snoring, gynecomastia, aggressiveness, all the, well, known side effects do occur in different proportions of patients. I think acne and gynecomastia were the most bothersome to most subjects, and gynecomastia occurred in 25% of our group. So that's the rule of thumb. You'll have negative side effects and you'll have positive side effects. The balance between them, you'll have to find out yourself, but usually the positive effects outweigh the negative effects because the negative effects are minor, they can be treated with medication, and they are reversible. We examined effects on kidney, liver, and prostate. These are graphs that show the PSA, so the prostate-specific antigen during the cycle. This is before the cycle, this is during the cycle, this is after the cycle. You can see a peak in PSA levels. You can see a peak in ALOT, liver, kidney, injury values. And you can see a peak in creatinine, which displays kidney function. So there is liver irritation during the cycle. There is a reduction of kidney function, but all of them seem to be reversible. And looking at the size effect, the effect size, this is not worrisome. These are minor effects. Cardiovascular parameters are probably the most important parameters that we investigated. Cardiovascular parameters are important because they might predict heart disease in a later age. Some of them you don't influence at all. Aging, gender, ethnicity, and genetic predisposition are fixed, but many of them are modifiable, like weight and dyslipidemia, hypertension, alcohol, and some of them we investigated. We investigated blood pressure, which is a very important risk factor for heart disease. And looking at these graphs, you can see that systolic blood pressure increases from 130 to 135 during the cycle and reverses back to normal after the cycle. And diastolic blood pressure shows the same movement along the graph. These again are very minor effects, but they are altogether accumulating and might lead to an enhanced cardiovascular risk profile. Looking at blood cells, we see the same picture for hematocrit, which is the amount of red blood cells that you have in the blood. Too many is not too good because they predispose to thromboembolic disease or cardiovascular disease. And we can see a spike of hematocrit during the cycle, an increase of about 5%, which is very logical because testosterone induces EPO production, and EPO leads to higher hematocrit, which is unfavorable. Again, individually, the effects are small, but they are very discernible. And altogether with lipid and blood pressure, they might really increase the risk profile of heart disease. We saw an increase in platelet count, the cells that are responsible for clotting. There's a sharp increase of platelet count during the cycle. And again, this is reversible. Lipids, obviously a very important topic. We saw a very consistent increase of LDL cholesterol, the bad cholesterol that causes atherosclerosis, and a decline of HDL cholesterol in the group. Each bar indicates a separate individual. With LDL cholesterol, there was actually a group that had better cholesterol during the cycle, which I think is the result of a different diet. But almost all of them had a lower HDL cholesterol, which is unfavorable. We also looked at coagulation factors. This is a graph that is very hard to interpret because these all are coagulation factors, factor 2, 9, von Willebrand factor, D-dimer. You don't have to know what they do. You just have to know if there's a green bar, it means that there was an anticoagulant change during the cycle. And if there's a red bar, there was a procoagulant change during the cycle, which means that there's more red than green. Blood easily clots and might lead to thrombosis and embolism. We saw different effects of different factors during the cycle. So it was very hard to determine which of these changes prevailed. So we did the ETP, which is a test that basically summarizes the effect of any compound on blood coagulation. And we see a small anticoagulant change during the cycle. So that seems to be quite protective. We didn't find data that would support the risk of thrombosis or embolism during a cycle because we had the impression that blood gets slightly thinner when using androgens. So that was a surprise. That was new information. The other analysis that we did was a cardiac analysis. We did echocardiography and electrocardiography to assess the heart rhythm. Electrocardiography shows a couple of things that we would have predicted beforehand. We see as a higher heart rate. That's probably because the ejection fraction, the power of the heart somewhat decreases. We see indices that indicate that the heart muscle gets thicker. When we saw these changes, that's when we decided to do echocardiography, because we were intrigued whether it would mean that the heart muscle actually changes. So that's the next thing that we did. And indeed, in about 30 of the 100 subjects, we did echocardiography, and we saw that the LVEF, which is the percentage of blood that is pumped out of the heart with every heartbeat, declines from about 65% to 55%, which means that the heart loses about 10% of strength, of pumping potential during the cycle, which is a big deal. This is not a very big change because as long as this stays above 35%, a patient won't really notice any different. You will be able to exercise normally. You will be able to climb a couple of stairs without getting out of breath. But if you would put this on top of a heart that is not functioning very properly, or you would continue using year after year, there's going to be a problem with your heart. And that is the examples that we are seeing quite often in the news and in the literature, that very heavy users of anabolic steroids that don't take breaks have to deal with cardiomyopathy and heart disease. But also these changes, as long as the subjects quit their cycle, seem to be reversible. There was, up till now, in the data that I showed you, not any parameter that didn't change back to baseline after they quit the cycle, which is important information. But the endocrine effects were slightly different. Endocrine effects are the testosterone and the fertility. This graph on the left shows the testosterone levels before and after the cycle, not during the cycle, because during the cycle they were, of course, extremely high, so they would really distort the graph. And you can see that the testosterone levels before and after the cycle remained very constant. So testosterone concentration seems to recover in almost all patients or almost all subjects that we analyzed. Looking at testicular volume on the right side, we see the same picture, but looking at total sperm count, fertility, how much sperm cells do you have in an ejaculate, recovery seems to be much lower. And this is the only parameter in which we could see a clear picture of incomplete recovery. If your sperm production is about 100 million in your first ejaculate before you start a cycle, it will get close to zero during the cycle, but not recover all the way back to normal afterwards. We did a follow-up of a year, we did a follow-up of 2 years, and after 2 years, this picture didn't really change. So there seems to be a permanent damaging influence of anabolic steroids on fertility, which is interesting, as it was the only factor that seemed to change permanently. If we plot fertility, this plot shows the total sperm count, so the level of fertility against time after the cycle. We did have the impression that if you wait long enough, there is some more recovery. So if you wait half a year, or maybe 2 years, there is a tendency for sperm to recover. But if you keep in mind that most of the users don't wait another year and don't even wait 2 years before they engage into a new cycle, you can imagine that in the long run, fertility is really affected by steroid use. Okay, I'm ending this presentation almost. As I've discussed almost all data, I'll skip this one because I want to talk about our next project as well and leave some room for Q&A. So the conclusions of our research of the HAARLEM study was, next to getting a real good picture of characteristics of users and the methods of anabolic steroids that they use and the reasons for them to use the steroids. I've discussed all of them, I won't repeat them. We did see that there were serious health issues in 4% of subjects. That might not seem much, but if you realize there's tens of thousands of anabolic steroid users in the community, we might encounter serious adverse events anyway in a large proportion. This 4% is maybe not composed of serious adverse events caused directly and only by the anabolic steroids, but in 2 of the 4, we had the impression that at least it played an important role. But if you want to say something more conclusive about the serious adverse events, you would need much larger groups. So it's hard to say. We observed important changes in cardiovascular health. And we have the impression that the amount of exposure during your life to anabolic steroids is probably related to long-term health issues. The changes that we see during the cycle, the cholesterol, the blood pressure, the hematocrit, they are minor, but if you are exposed to these minor changes for long enough, they will incur some cardiovascular risk. So although we are not able to say something really definitive about long-term health effects, we really have the impression that anabolic steroids are a risk factor for heart disease, like high blood pressure, like smoking, like cocaine use. So we should really pay attention to them when they get older. Besides that, and besides fertility, health effects are completely reversible. So there's always reason to quit the anabolic steroid use if you want to protect health. Looking at our population, you cannot be sure that this is a very representative group of users of the entire population, because we included the continuous users. There were some continuous users because they kept using anyway, even though we requested them not to do so. But there are continuous users of steroids in the population that we didn't really see in our study. We offered free healthcare, so we may have attracted a group of users that are more interested about their health than others. And we didn't include any females, so we aren't able to say anything about that group.